Hello, and thank you for inviting us to present at the GORE conference. We're presenting today on the partnership between Facebook and two academic institutions to field a COVID-19 daily tracking survey. These are Carnegie Mellon University in the United States and the University of Maryland globally. The goals of our presentation today are to describe the data collected since April 2020, to share early insights from researchers using the data, and to highlight challenges we encountered over the course of field collection, given both the speed and scale of the project. I'm presenting today with Professor Frauke Kreuter. Frauke is the Director of the Joint Program and Survey Methodology at the University of Maryland, and she is leading the Global Symptom Surveys project. I'm a research scientist on the Demography and Survey Science team at Facebook, which is a small part of the very large cross-functional group of researchers and engineers working to execute the survey sampling and weighting to provide technological web survey assistance to both UMD and CMU. The partnership was the result of a call from public health experts to build a rapid syndromic surveillance system for COVID-19. Syndromic surveillance, for those of you who are unaware of the term, enables policymakers and public health systems to make decisions before diagnosis data are available by using alternative data sources, including but not limited to survey responses. Using Facebook as a sampling frame for this effort offered several unique advantages. Most importantly, Facebook reaches large segments of the global population daily with the technical infrastructure to provide bias correction. And while there are certainly biases in a global social media tracking survey, we hope the trends in the weighted survey responses will enable important modeling and decision-making efforts. For example, forecasting how many cases local clinics or hospitals will see in the days ahead, providing an early indicator of where the outbreak is growing or where the curve is being successfully flattened, and assessing the social and economic effects of the pandemic, as well as adherence to preventative measures and policies. In our presentation today, we'll go over the unique project structure of the symptom surveys, the survey instruments and weights, some early insights from our partners, and reflections on data collection challenges. We designed this partnership with privacy in mind from the very start, but this required special considerations for the structure of the project and its scientific components. Each day, Facebook first invites a new random sample of users to participate. The survey uses a repeated cross-section design. Users may take the survey more than once over the course of field collection, but their responses cannot be linked over time. Users are sampled using a stratified random sample at the subnational region level to ensure geographic representativeness within countries and to allow for unique small area estimation procedures. Users who navigate to the survey are sent to the instrument hosted by our academic partners using Qualtrics. Facebook does not receive responses, but does calculate weights to correct for random sampling, non-response, and sampling frame coverage biases using internal company data. We do so by receiving only the random digit identifiers of respondents who completed the survey, and then sharing back only the random digit identifiers along with their corresponding survey weights. Aggregate weighted estimates provided by UMD and CMU are then made publicly available, and the non-aggregate microdata are available to researchers upon request. I'll turn it over now to Frauke.
Thank you and welcome everybody. This point we'll come back to later. I very much hope that this presentation will entice several of you to make use of the data or maybe apply for the use of the microdata. So let's look what's inside the data. The global survey as well as the US surveys are fielded independently, as Catherine just mentioned, but we have made the instruments comparable in several important ways. The global survey is available in more than 50 languages and is fielded, as Catherine said, in pretty much any country that Facebook is active. The survey instrument itself has 5 sections. We have a pretty long consent procedure. We have a section on health symptoms, the early COVID-like symptoms or influenza-like symptoms. Then we have a section on social distancing behavior, contacts with others, a section on mental health and economic security, as well as a set of demographic questions at the end. What's interesting is that we closely developed this questionnaire, not just with several academics who had suggested to Facebook to engage in this US-wide and global symptom survey, but also with large organizations such as the World Health Organization and to some extent the World Bank, for example, to capture needs that the WHO has, but also to make sure that we synchronize the data collection among many different other data collections that are in the field currently. The US survey is available in 6 languages, obviously English and then 5 others. It has similar sections, and as I said, the first 2 months, the surveys were a little bit less connected, but now the data are quite comparable across the two. The sampling rate in the US is somewhat higher than in the other countries, allowing for small area estimation, specifically county level in the US. So as of June, we had received more than 9 million responses to the UMD Global Survey from respondents in more than 200 countries or territories globally, averaging about 230,000 responses every day and 1.6 million responses every 7 days. We received about 6 million responses to the Carnegie Mellon survey in the United States, averaging about 71,000 every day and 500,000 responses every 7 days. So I'm happy to talk about more of that in the discussion if you like. One important piece, and Catherine, maybe you want to mute yourself while I'm presenting, just so we avoid the feedback. The one important piece to consider here is the bias correction that we mentioned. We have, of course, we receive the analytic weights that Facebook provides, and we have no insights into the variables that go in there either. We really try to keep these two data worlds completely separate. But we've worked with them on the procedure on how to adjust for non-response and how to adjust for coverage bias. By non-response, we mean that someone who is sampled as a user and has the chance to respond, and then doesn't get the weight attached to it that reflects the likelihood to respond to the survey. To adjust for this, Facebook first calculates the inverse probability that sampled users complete the survey using their self-reported age and gender, as well as other characteristics that they know correlates with non-response to the web survey. And then we use Facebook in a sense uses the inverse probability to create the weights. The coverage bias, on the other hand, means that not everyone in every country is on Facebook, obviously, right? That varies a lot. And to adjust for this, Facebook adjusts the weights created in the first step even further by using known population distributions of age and gender in the various countries and territories, so that at least we have a little bit of an adjustment by age and gender according to the Facebook participation. This won't be ideal for point estimates, but we feel pretty good about that setup as we compare daily changes. And the whole beauty of this particular sample is to sort of look at the development over time. Survey weights are available for 115 countries. We are, revising them depending on coverage, depending on, rates people respond to the survey. We have, as Kathleen mentioned, a strong privacy focus and always have an eye on having sufficient respondent in each of the cases. Individuals cannot be identified neither with the aggregate data nor with the individual microdata. So moving to early insights from the survey responses that we have seen and colleagues of us have created. Pretty interesting, the work from the CMU Delphi Research Center. They developed trends for short-term hospitalization forecasts in the US, and they combined this particular survey data with other sources of data that they had. They find that the symptom survey shows promising correlation with conformed case numbers, though the correlation varies a lot by geography, they also found. The Institute for Health Metrics and Evaluation at the University of Washington has begun looking at the international data, looking again at correlates of the symptom survey, but also at other indicators such as mask use in several regions. The WHO regions are displayed here on the slide, but they've done this for many different, not just Africa, but many different other regions, both sort of point in time, but also across time. It will be interesting for anyone wanting to jump on this to compare these with sort of metrics and measures taken by various countries to see the effectiveness. Now, I want to mention a couple of data collection challenges that we faced. This has vastly exceeded anything I've ever seen or done. Doing a survey on a global scale with so many people, both stakeholders but also respondent, has really unforeseen challenges. Just a quick anecdote: at the very beginning, we had on the invitation side a hot link to the email address or my email address for questions, instead of just the link mentioned so that you can type it up if you really have a question. And I got so many people who just hit the hot link and then, instead of answering the structured survey, just wrote out how they're doing, what their symptoms are, and what their current situation is. And they got tons of emails of that sort in all kinds of languages. So thanks to Google Translate, I could figure out what was going on. We realized this was the issue of the hot link and resolved it. But since this survey is so large, you know, anything scales and quickly spirals out of control. There are other issues like, you know, just having 50 languages supported by a survey, country tickers, and, you know, doing this sort of with this massive use is a challenge to any platform that you have. But also when you plan something like this, it's important to have the complete pipeline in mind, including the sharing out of the data, because, you know, particularly with GDPR these days, you know, in hindsight, it could have been useful to have separate regulations for the data use, those in GDPR related countries and those that are not, things like that. We did not have, when this started, enough time to translate or to do back translation and care for pre-testing, but we did, while the, you know, built this while the airplane was already flying, if you will. And I have to say, heads off to the Facebook translation teams that helped us. Our independent translator found very few errors, and those were easily fixed. So with that, I'm turning it back over to Catherine, who can talk about the data access.
Thanks, Frauke. So with more than 2.5 billion users worldwide, Facebook provides a unique window into the world, as we hope we've shown. We believe strongly that when privacy is protected and when shared responsibly, data is shared responsibly, that communities can benefit and we can all become healthier and improve well-being. The data are available for responsible use, and we hope you use them for your research. The aggregate weighted estimates of COVID-like illness calculated by our partners at UMD and CMU are available publicly via their APIs hosted on their websites. The non-aggregate microdata are freely available by request through a portal on Facebook's Data for Good website. In addition to partnering with UMD and CMU to collect the symptom surveys, we provide several additional data sources to help with disease modeling efforts through the Data for Good program, and we encourage you to investigate them for your work. If you have any questions, please feel free to reach out via the email displayed on the screen. Thanks so much.